This is a 27-month-old boy who came in for respiratory distress. The story was the grandmother was with the child while the mother was out running errands, and grandmother reports the child was very upset and crying for several hours. Mother came home and noted that he seemed to be having some difficulty breathing, and he appeared blue around the lips. Any other history you're interested in? He had not been eating. In fact, grandmother had him for a while, got tired of him, and put him in the playpen.
What was he playing with?
What was he playing with? You mean in the playpen itself? A couple of toys. They did mention there was a pen in there, and they're not sure if they could find the cap for that pen when you asked them.
Does he have recent viral infection?
No recent infections, no fevers, no coughs, no nothing. Abnormal movement of his chest. Mom said he seemed to be really struggling to breathe. He was having some retractions. Mother's not on any medications, and he's not on any medications at this point. No trauma, no fevers, recent illnesses. He's not a snorer or asthmatic. We got worried about that again. Was playing with a felt tip pen. Pen cap's now missing, so that's certainly a bit of a concern. On arrival, he's anxious. He's in moderate respiratory distress. There's his vital signs. He's a little bit tachypnic for you. He seems to have central cyanosis. He has moderate retractions and has complete absence of breath sounds on the left. No stridor, rails, or wheezes noted. What are you thinking of now? Foreign body. And where's the foreign body in this case? It's sitting down on the left side. That's certainly highest on our list by a long shot. But what about just absent breath sounds on the left? What else would you include in your differential? Pneumothorax, I think somebody said hemothorax too. Might be able to tell a little bit of a difference by percussion of that area. How often do we percuss chest these days? What do we want to do with this kid? You want a chest x-ray, and we might even want to get ENT available for him. So as our differential diagnosis, foreign body pneumonia could just be a straight pneumonia, although he's not been febrile. It seems a little bit odd that that would be the case. Spontaneous pneumothorax or hemothorax. Before we do that, we want to certainly give him some oxygen, put him on his monitors. Somebody said a chest x-ray, ENT. How about back blows or the Heimlich for this guy? Indicated for him? No. He's still got an open airway. He's still doing some breathing. Back blows and Heimlich is not going to dislodge it if it's down in the main stem bronchus, not indicated for us. Here's our x-ray. If you want to change your mind, now what he's got. Here's his main stem, right main stem, left main stem, mediastinum pushed way over. That's not a foreign body right there. So what do we want to do for this? Respiratory distress increases. What are you going to do for this kid? Okay, you get intubated. I mean, before that, what do you have to do for this? What's the treatment for tension pneumothorax right now? Needle his chest. We put a big 14-gauge IV needle, second intercostal space, mid-clavicular line on the left. Needle thoracentesis was done. Here it is. No big wish of air. What's our next step for a pneumothorax? Put in a chest tube. We put the chest tube. It looks like it's high there, but that is actually the fourth intercostal space. Up it goes. He's no better. No improvement. What do you want to do? People want an NG. Okay, we put in an NG tube. Markedly better. What's he got? He's got a diaphragmatic hernia. Here's our NG tube. See it going down there? See it right up there? What was that we were looking at on the chest x-ray? That was his stomach up there in his chest. Exactly. This is a late presenting diaphragmatic hernia. Not too common, but we've seen a number of these. They are commonly mistaken for a tension pneumothorax or sometimes pneumonia if there's a lot of fluid in the stomach and it's up in that area. Obviously, that's what we mistook it for also. There happens to be a 20% incidence of viscous perforation with the chest tube placement because so many of these kids get this. In fact, at the same time, at another institution across town, they had almost an identical case, and they got a lot of relief from their chest tube, but they also got some stomach contents when they put the chest tube in. They actually did cause perforation, so we felt better that we didn't do that, at least. These children have normal lungs, so this is very different than the acquired diaphragmatic hernia where the lungs never develop because there's no room for it to develop. These children had normal lungs. As soon as you remove the contents out of the chest back into the abdomen, the lung re-expands and does fine. Here's the operative view of this child. You can see that rent right there in the diaphragm that they've just finished sewing up. They pulled out the stomach, a fair amount of intestines, and the spleen was up in there too. Had to pull it all back down, so no wonder he was having difficulty with his breathing. Of course, many people pointed this out to us afterwards, the mistakes that we had made in this case. If you look at the X-ray, there is a few more clues here. This has a radio-opaque membrane that surrounds that area, and that would be the gastric wall right there. Next, the lucency does extend down below the diaphragm. Usually we should see a very sharp diaphragm if it's just a tension pneumothorax. Last, the lung with a tension pneumothorax is compressed towards the hilum. In this case, it's compressed outward here. Okay, I'm convinced that it wasn't a tension pneumothorax, but this is a D hernia. If you think about the likely course in this particular patient, he was crying, he swallowed a lot of air. Children will do that. Their stomach expands dramatically at times, causing increased intra-abdominal distension. Now, there was probably a weakness in this patient anyway, through which the area herniated. It finally just gave with that increased pressure, so there was probably a predisposition to this. We do see in other cases, too, the most common has been abdominal trauma. A lap belt in the area can cause enough intra-abdominal pressure to force contents up through a rent in the diaphragm. Child abuse with a blow to the abdomen would be another route for that. It can present in many different ways. This was obviously very acute, but there's some chronic cases where they present the same way you might see with a hiatal hernia with frequent reflux and vomiting. Some are completely asymptomatic. I've seen some that have shown up when they've got an X-ray for cough and fever, concern of pneumonia, and all of a sudden there it is. It can be very subtle, but it can be very dramatic, as in this case.